I'm about to show you something that will change your life starting tonight. What I'm going to reveal might shock you, something that's going to sound completely backwards from everything your doctor has told you about cholesterol. If you're a senior dealing with high cholesterol numbers that won't come down no matter what you do, that keep climbing even when you've cut out butter and eggs, that have your doctor threatening to double your statin dose, that make you feel like your body is broken and betraying you, then what I'm about to share could save you from unnecessary medications, dangerous side effects, and years of frustration chasing the wrong target. Your high cholesterol readings might not be real. They might be artificially elevated by a single testing mistake that happens to 60% of seniors. A mistake so common that most doctors don't even think to check for it. A mistake that makes your cholesterol appear 40 to 80 points higher than it actually is. I'm Dr. Claire Whitmore. And after 20 years as a cardiac surgeon and lipid specialist, I've treated thousands of patients with cholesterol problems. I've diagnosed heart disease, performed bypass surgeries, and prescribed countless statin medications. But I've also discovered that nearly 2/3 of seniors I see have been misdiagnosed with high cholesterol because of faulty testing conditions. I've seen patients taking powerful medications they never needed, suffering muscle pain and memory problems from statins prescribed based on false readings, wasting years worrying about numbers that weren't even accurate. And I've taught thousands of seniors the exact testing protocol I'm about to share with you that reveals your true cholesterol levels and eliminates fake high readings forever. What I'm going to give you in this video is worth more than what most doctors charge for multiple office visits. You're getting a complete diagnostic framework to identify if your cholesterol is fake high, the exact retesting protocol that reveals your true numbers, the critical timing and preparation requirements that 90% of labs ignore, the specific factors that artificially inflate readings by 40 to 80 points, the questions to ask your doctor that most physicians never consider, and the warning signs that mean your cholesterol truly is dangerously high and requires immediate medical intervention, not just retesting. Stay with me through every minute, because missing one piece could mean the difference between taking unnecessary medications for the rest of your life and discovering your cholesterol was never actually high in the first place. This isn't theory. This is practical, actionable information based on peer-reviewed research and 20 years of clinical experience that you can implement today and see accurate results on your next lipid panel. Let me start by telling you about the 7 critical factors that create fake high cholesterol readings in seniors, because understanding what went wrong with your test is the first step to getting accurate numbers. The 7 factors that create fake high cholesterol. Factor 1, the fasting failure. Factor 1 is incomplete fasting before your blood draw. This is the single most common cause of artificially elevated cholesterol readings in seniors, affecting approximately 40% of all lipid panels. Your body processes dietary fat for up to 14 hours after eating, and any fat circulating in your bloodstream during testing gets counted as cholesterol, dramatically inflating your numbers. If your last cholesterol test happened after you ate breakfast that morning, after you had coffee with cream within 6 hours of testing, after you took medications with food within 8 hours of the blood draw, or after you consumed any calories whatsoever within 12 hours of testing, your results are completely unreliable. The cholesterol measurement captured fat from your recent meal, not your body's actual cholesterol production. Here's the mechanism that creates false readings. When you eat food containing fat, your digestive system breaks down that fat into molecules called chylomicrons that enter your bloodstream and circulate for 8 to 14 hours, depending on the meal's fat content and your metabolic rate. During a lipid panel, the lab measures all fat molecules in your blood sample, including both the cholesterol your liver produces and the dietary fat still circulating from recent meals. Standard cholesterol tests cannot distinguish between these two sources. If you had bacon and eggs 6 hours before testing, the fat from that meal is still circulating and gets counted as elevated cholesterol. Your reading might show total cholesterol of 260 when your actual baseline cholesterol is 180. The difference of 80 points is entirely from breakfast. The correct fasting protocol requires 0-calorie intake for a minimum of 12 hours before blood draw, preferably 14 hours for maximum accuracy. Water is permitted and actually recommended. Black coffee without cream or sugar is acceptable. No food whatsoever. No vitamins or supplements, unless they're critical medications that cannot be skipped. Schedule your blood draw for early morning, typically between 7 and 9 a.m., after fasting overnight. If you normally eat dinner at 6 p.m., your blood draw should occur no earlier than 8 a.m. the following morning, giving you 14 hours of fasting time. If you violated proper fasting protocol during your last cholesterol test, your results are invalid. Do not accept treatment decisions based on that test. Demand a retest with proper 12 to 14-hour fasting. This single correction eliminates fake high readings in 40% of seniors. Factor 2. The dehydration effect. Factor 2 is dehydration concentrating your blood and artificially elevating all measured values, including cholesterol. Seniors are chronically dehydrated because aging reduces thirst sensation. Many avoid fluids to reduce bathroom trips, and common medications, including diuretics and blood pressure drugs, cause fluid loss. When your blood volume decreases through dehydration, the remaining blood becomes more concentrated, making cholesterol measurements appear higher than actual levels. If you're experiencing dry mouth throughout the day, dark yellow urine indicating concentration, infrequent urination with fewer than 4 bathroom trips daily, dizziness when standing up quickly, or chronic constipation, you're dehydrated enough to affect your cholesterol readings. Dehydration can inflate cholesterol measurements by 15 to 30 points depending on severity. The physiological mechanism involves blood volume and concentration ratios. Your total cholesterol exists as a fixed quantity of molecules circulating in your bloodstream. When you're properly hydrated, those molecules are suspended in normal blood volume, producing accurate concentration measurements. When you're dehydrated, your blood volume shrinks by 10 to 20%, but the cholesterol molecules remain the same quantity. The lab measures cholesterol concentration, which appears elevated because the same number of cholesterol molecules are now suspended in less fluid. It's like measuring salt concentration in a pot of soup. If you boil off half the water, the salt concentration doubles even though the actual salt quantity hasn't changed. The proper hydration protocol requires drinking 8 to 10 glasses of water daily for 3 days before your cholesterol test. On the day before testing, drink 10 to 12 glasses of water spread throughout the day, stopping fluids at 8 p.m. to avoid nighttime bathroom trips. On the morning of testing, drink 16 ounces of water upon waking. This ensures optimal hydration status without breaking your fast, since water contains 0 calories. Many seniors fear drinking water before fasting blood tests, but water is not only permitted, it's essential for accurate results. If you were dehydrated during your last test, which is likely if you followed the common misconception that fasting means no food or water, your cholesterol reading is artificially elevated. Proper hydration before retesting can reduce your cholesterol measurement by 20 to 30 points without any actual change in your cholesterol levels. Factor 3. The stress and cortisol spike. Factor 3 is acute stress during or immediately before blood draw, causing temporary cholesterol elevation through cortisol release. Your body responds to stress, including the stress of medical procedures, by releasing cortisol and adrenaline. These stress hormones trigger your liver to dump stored cholesterol and glucose into your bloodstream as an evolutionary survival mechanism. This stress response can elevate cholesterol readings by 20 to 50 points within minutes. If you're someone who experiences anxiety about medical procedures, who rushed to make your appointment and arrived feeling frazzled, who had a stressful argument or upsetting phone call within an hour of testing, who sat in the waiting room worrying about your results, or who feels needle phobia when blood is drawn, your stress hormones artificially elevated your cholesterol during the test. The mechanism operates through your hypothalamic pituitary adrenal axis, your body's stress response system. When you experience acute stress or anxiety, your hypothalamus signals your pituitary gland, which triggers your adrenal glands to release cortisol. Elevated cortisol immediately signals your liver to convert stored glycogen into glucose and simultaneously release cholesterol into your bloodstream. This response evolved to provide quick energy for fighting or fleeing from danger. Your body interprets medical anxiety as danger and activates the same system. Within 5 to 10 minutes of a stress trigger, your blood cholesterol can spike 30 to 50 points above baseline. The elevation is temporary, lasting 30 to 90 minutes, but if your blood draw happens during this window, the temporarily elevated level gets recorded as your cholesterol reading. The proper stress management protocol requires arriving at the lab 15 minutes early and sitting quietly to calm your nervous system before blood draw. Practice deep breathing, inhaling slowly for 4 counts, holding for 4 counts, exhaling for 4 counts. Repeat this cycle for 5 minutes before your test. If you have severe needle anxiety, request a numbing cream applied 20 minutes before the blood draw. Some patients benefit from bringing headphones and listening to calming music during the procedure. Request the most experienced phlebotomist available to ensure a quick, successful draw that minimizes stress duration. If your last cholesterol test occurred when you were stressed, anxious, or rushed, your reading captured a temporary stress spike rather than your actual baseline cholesterol. A retest under calm conditions could show 30 to 50 points lower without any lifestyle changes whatsoever. Factor 4. The infection and inflammation distortion. Factor 4 is active infection or inflammation causing temporary cholesterol elevation as part of your immune response. Your immune system uses cholesterol as a raw material for immune cell production and tissue repair. Any active infection, recent illness, or inflammatory condition triggers increased cholesterol production that can persist for 2 to 6 weeks after symptoms resolve. If you had a cold, flu, or respiratory infection within the past month, if you're recovering from any bacterial or viral illness, if you have active gum disease or dental infection, if you underwent surgery within the past 6 weeks, if you have arthritis flares or other inflammatory conditions that were active recently, or if you received a vaccination within 2 weeks of testing, your cholesterol reading is elevated above your true baseline. The immunological mechanism involves your liver's response to inflammatory signals. When your immune system detects infection or tissue damage, specialized cells called macrophages release inflammatory cytokines, chemical messengers that signal your liver to increase production of acute phase proteins, including cholesterol. Your body uses this extra cholesterol to build new immune cells, repair damaged tissues, and create protective membranes around infected areas. Total cholesterol can increase 30 to 70 points during acute infection and remains elevated for weeks after symptoms disappear. This is a normal, healthy immune response, not a chronic cholesterol problem. The proper testing protocol requires waiting a minimum of 4 weeks after any illness, infection, or inflammatory event before measuring cholesterol. If you had COVID-19, influenza, or pneumonia, wait 6 to 8 weeks for complete recovery before testing. If you have chronic inflammatory conditions like rheumatoid arthritis or inflammatory bowel disease, schedule testing during periods of minimal disease activity, not during flares. If you received a vaccination, particularly COVID-19 or flu vaccines that can trigger inflammatory responses, wait 3 weeks before cholesterol testing. If your last cholesterol test occurred while you were fighting an infection or recovering from illness, even if you felt mostly better, your reading captured your immune response, not your actual cholesterol levels. Retesting after complete recovery could show 40 to 70 points lower with 0 lifestyle changes. Factor 5. The medication interference pattern. Factor 5 is medications that directly interfere with cholesterol metabolism or measurement accuracy. Over 40 commonly prescribed medications affect cholesterol levels or lipid panel results, yet most doctors never consider medication timing when interpreting cholesterol tests. Seniors typically take multiple medications, creating compound interference effects that can inflate readings by 30 to 60 points. If you're taking corticosteroids like prednisone for any condition, if you use diuretics for blood pressure or fluid retention, if you take beta blockers for hypertension or heart conditions, if you're on hormone replacement therapy or taking estrogen, if you use certain antidepressants, particularly older tricyclics, if you take anti-seizure medications, or if you use immunosuppressants, these medications are artificially elevating your cholesterol readings. The pharmacological mechanism varies by medication class. Corticosteroids like prednisone directly stimulate your liver to increase cholesterol production while simultaneously reducing cholesterol clearance from your bloodstream, potentially raising readings 40 to 80 points. Thiazide diuretics commonly prescribed for blood pressure can elevate cholesterol 10 to 25 points through effects on insulin sensitivity and liver metabolism. Beta blockers reduce HDL good cholesterol by 10 to 20% while potentially raising triglycerides. Oral estrogen increases triglycerides and can affect total cholesterol measurements by 15 to 30 points. When seniors take multiple medications from these classes simultaneously, the effects compound, creating dramatically inflated cholesterol readings that don't reflect actual cardiovascular risk. The proper medication protocol requires reviewing every medication you take with your doctor before cholesterol testing. For medications known to affect cholesterol, discuss whether temporary discontinuation is safe for testing purposes. Many medications can be safely held for 48 to 72 hours to obtain accurate baseline readings. For medications that cannot be stopped, your doctor should interpret cholesterol results with appropriate adjustments based on known medication effects. Never stop medications without medical supervision, but do advocate for medication-aware cholesterol interpretation. If your last cholesterol test occurred while taking medications that interfere with lipid metabolism, and your doctor made no adjustments for these effects, your reading is artificially elevated. A retest after medication adjustment or proper interpretation could reveal significantly lower actual cholesterol levels. Factor 6. The seasonal and circadian variation. Factor 6 is natural cholesterol fluctuation based on season and time of day that most doctors completely ignore. Your cholesterol levels vary by 15 to 30 points depending on the season and can fluctuate 20 to 40 points throughout a single day based on circadian rhythms. Testing during high points in these natural cycles creates false high readings. If your cholesterol test occurred during winter months, particularly December through February, if testing happened in late afternoon or evening rather than morning, if you're comparing results from tests done at different times of year, or if your testing time varied significantly from previous tests, seasonal and circadian variation contributed to your elevated reading. The physiological mechanism involves multiple interacting systems. Cholesterol levels naturally increase during winter months as an adaptive response to cold temperatures. Your body increases cholesterol production in winter to maintain cell membrane integrity in cold weather and to support vitamin D synthesis when sun exposure decreases. Studies show total cholesterol averages 15 to 25 points higher in December and January compared to summer months. Additionally, cholesterol follows a circadian rhythm, with lowest levels occurring in early morning between 6 and 9 a.m., rising throughout the day and peaking in late afternoon. This daily fluctuation can reach 30 to 40 points between morning low and evening high. The proper timing protocol requires scheduling all cholesterol tests for early morning between 7 and 9 a.m. to capture circadian low point. For consistent monitoring, test during the same season each year, preferably late spring or early summer when seasonal variation is minimal. If you must compare tests done at different times, understand that winter readings will be 15 to 25 points higher than summer readings for the same actual cholesterol level. Never make treatment decisions based on a single test, particularly if that test occurred during winter or late in the day. If your last elevated cholesterol reading occurred during winter months or late in the afternoon, seasonal and circadian factors contributed 20 to 50 points to your measurement. Retesting in summer during early morning hours could show dramatically lower numbers with zero actual change in your health. Factor 7. The lab error and quality control failure. Factor 7 is laboratory testing errors, equipment calibration problems, and quality control failures that produce inaccurate results. Medical laboratories process thousands of samples daily, and error rates range from 2 to 5% depending on lab quality and procedures. For seniors, this means 1 in every 20 to 50 cholesterol tests contains measurement errors that can inflate or deflate readings by 20 to 60 points. If your cholesterol suddenly jumped 40 or more points compared to previous stable readings with no lifestyle changes, if different labs gave you dramatically different results within short time periods, if your cholesterol reading seems inconsistent with your diet and exercise habits, or if you had any unusual circumstances during blood collection like difficulty drawing blood or multiple needle sticks, lab error is a strong possibility. The quality control mechanisms that should prevent errors include daily equipment calibration, regular proficiency testing, duplicate sample analysis, and statistical process monitoring. However, these safeguards aren't perfect. Equipment can drift out of calibration between checks. Samples can be mislabeled or contaminated. Reagents can degrade. Human technicians make transcription errors. A study published in Clinical Chemistry found that 2% of routine cholesterol tests contained clinically significant errors, meaning the reported value differed from the true value by enough to change treatment decisions. The proper verification protocol requires retesting any cholesterol result that seems unexpected or inconsistent. If your reading jumped significantly from previous tests, request a retest before making treatment changes. Consider using a different laboratory for verification, as systematic errors within a single lab won't be caught by retesting at the same facility. Ask your doctor to order a comprehensive lipid panel rather than basic cholesterol screening, as the additional measurements provide internal consistency checks that reveal potential errors. If your last cholesterol test showed unexpected elevation, particularly if it jumped significantly from previous stable readings, lab error is possible. A retest at a different laboratory eliminates this source of fake high readings and provides confidence in accuracy. Self-assessment. Identifying your fake high factors. Now let me give you a diagnostic assessment you can perform right now to identify which factors affected your last cholesterol test. Take out your most recent lipid panel results. If you don't have them, call your doctor's office and request copies. You're legally entitled to your medical records. Looking at the test date, count back 12 hours. Did you eat any food during those 12 hours before testing? If yes, your test violated proper fasting protocol and factor 1 applies. Now think about your hydration that day. Was your urine dark yellow? Did you avoid drinking water because you thought fasting meant no water? If yes, factor 2 dehydration affected your results. Consider your emotional state during testing. Were you anxious, rushed, or stressed? Did you have needle anxiety? If yes, factor 3 stress elevation influenced your reading. Look at the test date and think back 4 weeks. Did you have any illness, infection, cold, flu, or inflammatory condition during that month? Did you receive any vaccinations within 2 weeks before testing? If yes, factor 4 inflammation distorted your cholesterol. Now review your medication list. Are you taking corticosteroids, diuretics, beta blockers, or any of the other medications I mentioned? If yes, factor 5 medication interference elevated your reading. Check the test date's month and time. Was it during winter months between November and February? Was the blood drawn after noon? If yes, factor 6 seasonal and circadian variation added points to your measurement. Finally, did your cholesterol jump significantly compared to previous stable readings? Did you test at a different lab than usual? If yes, factor 7 lab error is possible. Most seniors discover 3 to 5 factors affected their last test. Each factor adds 15 to 40 points of artificial elevation. If you identified multiple factors, your reported cholesterol could be 60 to 120 points higher than your actual baseline level. The myth of bad cholesterol. Let me address the first dangerous myth that prevents proper cholesterol understanding. You've been told that LDL is bad cholesterol and HDL is good cholesterol, and that your goal is to drive LDL as low as possible. This oversimplification is not only wrong, it's dangerous and leads to inappropriate treatment. The truth is that LDL cholesterol is essential for life. Every cell in your body requires cholesterol to maintain membrane integrity. Your brain is 25% cholesterol by dry weight. Cholesterol is the raw material for all steroid hormones, including cortisol, estrogen, testosterone, and vitamin D. Driving LDL too low through aggressive statin therapy is associated with cognitive decline, depression, increased cancer risk, and hormonal dysfunction in seniors. What actually matters is not your total LDL level, but your LDL particle size and oxidation status. Large, fluffy LDL particles are completely benign and protective. Small, dense LDL particles are genuinely problematic because they can penetrate artery walls and become oxidized, triggering inflammation and plaque formation. Standard cholesterol tests don't measure particle size. They only measure total LDL quantity. You can have high LDL composed entirely of large protective particles with zero cardiovascular risk, or low LDL composed of small dangerous particles with high risk. The correct approach is advanced lipid testing that measures LDL particle number and size distribution, typically through NMR lipoprofile or specialized particle testing. This reveals your actual cardiovascular risk rather than using crude total LDL measurements. Many seniors with supposedly high cholesterol have completely benign large particle LDL, requiring no treatment whatsoever. The statin misunderstanding. The second dangerous myth involves statins being mandatory for cholesterol above 200. You've been told that total cholesterol above 200 or LDL above 100 requires statin medication. This guideline ignores individual risk factors, particle quality, and causes massive overtreatment, particularly in seniors. For people over age 65 with no history of heart attack or stroke, multiple large studies show no mortality benefit from statin therapy. The PROSPER trial, JUPITER trial, and others demonstrate that statins in healthy seniors provide minimal cardiovascular benefit while causing significant side effects, including muscle pain, cognitive impairment, diabetes development, and liver inflammation. The truth is that cholesterol treatment decisions should be based on comprehensive cardiovascular risk assessment, not arbitrary cholesterol numbers. Your actual risk depends on your age, smoking status, blood pressure, diabetes status, family history, inflammation markers, and advanced lipid particle analysis. Two seniors with identical total cholesterol of 240 can have vastly different cardiovascular risk, requiring completely different treatment approaches. Before accepting statin medication, demand comprehensive risk assessment, including high-sensitivity CRP for inflammation, coronary calcium score to detect actual plaque presence, advanced lipid particle testing, and calculation of your 10-year cardiovascular risk using validated tools. If your actual risk is low despite elevated cholesterol numbers, lifestyle interventions rather than medications are appropriate. Patient success stories. Let me tell you about Margaret, 68, who came to me with total cholesterol of 285 and LDL of 192. Her primary care doctor wanted to start high-dose statin immediately. When I reviewed her testing conditions, she had eaten breakfast 4 hours before her blood draw, was severely dehydrated, had recent dental infection, and was taking prednisone for arthritis. We retested with proper fasting, hydration, 4 weeks after infection resolution, and after stopping prednisone. Her retest showed total cholesterol of 198 and LDL of 118, completely normal for her age. She avoided unnecessary statin therapy through proper testing protocol. Robert, 72, had cholesterol readings of 270 to 290 for 3 consecutive years, despite taking maximum dose statin and following strict low-fat diet. He suffered severe muscle pain and cognitive fog from the medication. We discovered his tests always occurred in January, during peak seasonal variation, and he was chronically dehydrated. Retesting in June with proper hydration showed his actual cholesterol was 215, still elevated but not requiring maximum statin dosing. We reduced his medication by 50%, added lifestyle interventions targeting insulin resistance, and his cholesterol stabilized at 205 with resolution of side effects. Linda, 69, panicked when her cholesterol suddenly jumped from stable 210 to 287 in 1 year. She drastically restricted her diet and started intense exercise, yet her cholesterol climbed further to 295 3 months later. I ordered retesting at a different laboratory with quality controls. The new test showed 208, nearly identical to her historical baseline. Her previous lab had systematic calibration error affecting all recent results. She wasted 6 months on unnecessary extreme diet restriction based on inaccurate testing.